Hello and welcome to another episode. So, as you would have guessed already from the name, this change that happens in the ECG is because of hypokalemia. Now, you must have already been taught what are the changes. There is ST segment depression, prominence of U wave, T inversion. So, these are, you know, normally taught to everybody. But what is often overlooked while teaching this is that people fail to make the student understand why these changes are happening. So that's a common problem we see with ECG being taught to students. So that is exactly why I made sure to make this video so that I can help you understand why exactly these changes are happening in the ECG because of hypokalemia. So to make sure you understand this, you need to be thorough about two basic concepts. This over here is your ventricular action potential. So over here is a rapid depolarization and then comes the repolarization. So repolarization initially it is rapid. Okay, then this plateau phase and then late rapid is there. And then comes the baseline which is your RMP. So, when you talk about repolarization in general, potassium is involved. So, we're talking about hypokalemia. So, potassium is involved in the repolarization in general in our body. So, the first part, the rapid repolarization, has a transient outward potassium channel. And then comes a inverse rectifying potassium channel, and then a slow acting potassium channel. So these are important concepts that you need to understand. So first, there is a transient outward potassium channel, then a inverse rectifying potassium channel, and your slow acting potassium channel. And this is the current that is generated because of that. Keep this in mind. We'll use this a little later. Okay, so over here sodium is involved, in the plateau phase calcium is involved. Okay, so that is basic stuff. The next thing you need to be aware of is about your RMP, the resting membrane potential. So as you can see over here, the potassium is taken out of the cell. Potassium efflux takes place. Okay, so this generates your RMP. On the other hand, we have your sodium potassium ATPase, which actively pumps sodium outside, where sodium is actually more, and actively takes potassium inside, where potassium is again more. Okay, so this maintains RMP. So we'll just take a look at what it actually means. So your potassium efflux, some positive ion is going outside, so it tends to go towards the negative. So this ultimately reaches and keeps going out till it reaches its equilibrium potential, that is that of the potassium value. So that is why it comes to around minus 90 over here. Okay, so that is why potassium is very important for your resting membrane potential. Okay, now consider some current, depolarizing current is coming. Okay, and it results in some sort of a graded response, has not reached the threshold, voltage gated sodium channels are not activated, so there is a graded current. Okay, now what it does is your sodium potassium ATPase is going to take 3 sodium outside, 2 potassium inside. So in the end, one positive charge is being taken out. So ultimately that helps maintain RMP by bringing it back. So this is how RMP is generated. So potassium efflux generates RMP while your RMP is maintained by sodium potassium ATPase. Okay. So what exactly happens when potassium is low? The EC of potassium is low. So that essentially created a concentration gradient over here. Okay, potassium is much lower outside compared to inside. Okay, that is normally what happens, and potassium concentration falls even more. Okay, so logically thinking, potassium is supposed to go out, and this gradient has actually changed and resulted in more efflux actually. Okay, so if you think about it, now the whole concentration inside and outside has been altered, so that equilibrium potential value might change a bit. Okay, so you'd expect it to keep going higher like this. Okay, so now actually what do you see? The difference between your threshold potential and your RMP has increased. Okay, so this is kind of counterintuitive to what we're learning, because when you learn about hypokalemia, generally we say that your cardiac muscle goes into hyperexcitability. Okay, so this is where I'm pretty sure students must be having this sort of expression. Okay, and that again is why I made sure to make this video to help you understand what exactly happens. Okay, so let's take a look at it. So now that we come back to this, I was talking about your inverse rectifying potassium channel. So this is the important thing which is there in your plateau phase. And you know, plateau phase is very important, and that helps maintain your refractory period and everything. Okay, so this inverse rectifying potassium channel has a special characteristic that its activation is dependent on the extracellular fluid potassium. So it needs the extracellular potassium to actually activate it so that efflux can happen. Okay, so because of that, now if there is less extracellular potassium, the activation of this is hampered. So it's much more slower now. So once it is slower, this whole process will take longer and the duration of reaction potential increases, and that will kind of delay your repolarization. So that is essentially the concept you need to understand. Okay, so what happens because of that? You can see that the repolarization has got delayed. Okay, so you can see that the relative refractory period has increased because of this. So consider the next impulse to come over here. So your heart keeps beating. Yes. So the next impulse to come over here. So normally this would have been the baseline, the RMP, and it should have gone to the next potential, action potential. But over here, since this is prolonged and delayed, you can see that the next impulse falls on the relative refractory period. Okay, so that means the heart has not completely repolarized. Okay, so now from this point, it's actually easier for it to reach the threshold. So because of that, excitability has increased. So this is one of the reasons why your hypokalemia will result in increased excitability. Also, because this depolarization, X depolarization, began during the incompletely repolarized segment. Okay, so the muscle has not repolarized completely. Before that, the next depolarization will come. So that kind of makes the conduction slower. So this is especially important when you talk about your conductive fibers, especially in the Purkinje and all. This actually makes the conduction much slower. Okay. So ultimately, because of this increased excitability, conduction being slower, this will result in ectopics, supraventricular, ventricular, increased re-entry and all that. Okay, so I want you to take a look at this diagram. So over here, QRS complex, this is when your ventricular action potential starts. Okay, and this is your repolarization. So you can see the repolarization from here going on and all this taking place in the ECG. So this is a normal thing. So from here, what happened was when the concentration of your ECF potassium kept declining, what you can see is, you can see that the relative refractory period has increased. So initially this is there, and this is what is called tailing. So essentially what happened was the refractory period, relative refractory period especially, kept prolonging. That increased the excitability. The conduction also got delayed. Okay, and because of this delay in the repolarization, you can see that the T wave has become broad. And again, delay in repolarization means the U wave becomes more prominent because delayed repolarization of the papillae muscles, that is U wave. Okay, so these changes start happening. So in short, there was prolongation of the relative refractory period. Okay, this I'm not going to explain because that again is a separate topic which might just confuse you. Okay, so let's just stick to a prolongation of the relative refractory period. There is increased automaticity because your excitability is higher. Conduction velocity has decreased. Okay, that is because the muscle has not been repolarized completely. Now next is early after depolarization. What is that? So I'd shown you this. Okay, I hope this is clear. Now apart from this, there is another transporter which is involved over here. Okay, so sodium is taken outside, potassium is taken inside, so sodium is lesser inside. So that provides a gradient for sodium to come in, calcium to be taken out. So a normal sodium calcium exchanger is there. Okay, now when potassium is low outside, potassium needs to come from here and taken inside actively. Okay, so when potassium is low outside, it kind of inhibits the activity of sodium potassium ATPase to a degree. So when this is not there, this does not normally happen. So that means calcium will start accumulating inside. So increased calcium inside will result in early after depolarizations. Okay, and for this transient inward current is said to be involved. So what you see is from this, it is not repolarized completely, and your delayed after depolarization takes place like this over here. But instead, here you see early after depolarization, and that has increased chance to result in your tachycardias, ventricular fibrillations, torsades, pointus, and stuff like that, and difference in the re-entry. Okay, so all these things are more susceptible now because of this early after depolarization. So now that all of this basic functionality is clear, let's go on to understand how these are manifested in the ECG. As we had seen, repolarization problems were there. So delayed repolarization, so the prominent U wave is there, the T wave becomes broad, and then later on it gets inverted. ST segment depression is there, and when conduction abnormalities are there, that results in AV block. Okay, and the PR interval will start getting prolonged. So ultimately, all of these are because of these three things. There is repolarization, which is getting delayed, there's decreased conduction, and there is hyperexcitability. Okay, so that excitability partly because of your early after depolarization as well. Okay, so let's come to this and try to understand what happens. Okay, so now when you look at this and try to decipher what is happening, everything will be much more clear to you. So this is your normal tracing, the PQRS complex, T wave. Okay, so QRS is the depolarization, the J point is there where everything is depolarized, and from here on repolarization is starting. Okay, so when that is happening, you see that hypokalemia less than 3.5 milliequivalent. You can see that prominence of U wave, T wave has become broader and its amplitude has decreased. Okay, and over here you can see ST segment depression as well. So all these are because of repolarization problems. Delayed repolarization is resulting in all these problems. Okay, next you see T wave inversion when it gets worse. So hypokalemia progresses, it goes less than 2.5 milliequivalent per liter. You can see that this, because it takes more time, it kept broadening, amplitude kept decreasing, and eventually the inversion of T wave is there and U wave becomes more prominent. Also, there was a conduction problem. So in the conduction problem, because of that, you can see that the PR interval gets prolonged over here. Okay, so I hope this was useful for you to understand some basics about how hypokalemia results in your ECG changes.